Okay, so this is going to be our second congenital heart talk. This one is going to be more based around the cardiac surgeries that are done for congenital heart disease. And unlike some of my other talks that are more case based, this one is almost completely didactic. I'm going to start out with a quick comparison here. I want to make this point quickly before we get into the surgeries because this is highly testable. The right ventricle and the left ventricle are different. They're different in their function, and they're also different in their anatomy, and that anatomy in particular is testable. So the right ventricle is defined anatomically by the moderator band. So if you have a really complex congenital heart case and you're not sure what's what, the right ventricle is the one with the moderator band. Also, in the right ventricle, the papillary muscles insert on the interventricular septum, which is different than the left ventricle. In the left ventricle, the papillary muscles attach to the ventricular free wall. This stuff going on here. It's different. Because it's different, it makes it great this versus that, which makes each of these could make great distractors for the other one for multiple choice. So let's get into the surgeries here, and we'll talk about hypoplastic left heart first because it's by far the most complex. So just as a quick review, this is somebody who is born with essentially a left ventricle that is a completely worthless piece of shit, which is bad because you need your left ventricle as your primary systemic pump. So a lot of people have gone to a lot of trouble to develop a series of surgeries that are done for palliative purposes. They are not curative. These people do not live long lives. They live very short, horrible lives. But it's good for the Department of Radiology because they're sick and they get imaged a lot, and they also need G-tubes. So we try to squeeze as much suffering and money out of them at the same time as we can before they leave this world. So it's a 3-stage surgery. Surgeries, 3 stages are done, and the reason they aren't all done at once is because the kid won't survive them. They have to acclimate to each level. So starting out, there's a Norwood procedure which can utilize a Sano shunt, and that's done almost immediately after birth. That's followed up with a Glenn procedure that's done around 3 to 6 months, and then the last procedure that's done is a Fontaine procedure, which is done between 1.5 years and 5 years if the patient lives that long. So not only is the left side of the heart a worthless pump, you also have an aorta and an arch that is very small, and it creates basically an outlet obstruction on the left side. Doubly bad because you have a weak pump. Remember that they also have a high incidence of aortic coarctation. So this is a diagram, like schematic diagram that I did to show you the preoperative anatomy of a hypoplast. So just running through it quickly, they almost always have an ASD. They have a small aorta and a small arch. This is showing the pulmonary artery attached to the right ventricle normally with the PA, lungs, blood going back here. All right? So the first thing that's done is that they anastomose the pulmonary artery and the aorta to sort of make a large mega trunk, and that helps create unobstructed outlet flow from the systemic ventricle, which is the goal of the Norwood procedure. The second thing that's done is that they try to make the arch bigger, so they put a graft or augment it in other ways. And then finally, the ASD is enlarged, and that helps create less restriction to the flow there. So you're basically trying to give the systemic blood a way to get out. That's the primary objective of stage 1. Lastly, a Blalock-Taussig shunt is used between the right subclavian and right pulmonary arteries, or something like that. Notice that this is an artery-to-artery shunt. The if you happen to have a patent ductus, that is taken down, and the reason that they take that down is if they don't, you'll have too much shunting and they'll develop pulmonary edema, which is one of the major complications or stigmata of this surgery. There's an alternative procedure that can be done because, let's go back here, this Blalock-Taussig shunt essentially causes a subclavian steal syndrome because your pulmonary artery is taking blood from your subclavian because it's a low-pressure system, so you would have subclavian steal symptoms potentially. Now, to avoid that, a Sano shunt can be used, which is basically a shunt from the right ventricle directly into the pulmonary artery. So this is the overview here. This is the changes that have been made within the Norwood procedure. And remember, this is done very early on. And the goal, if you can remember, is to create less restriction to the systemic blood flow. So anastomosed aorta and pulmonary artery, bigger arch, and then you have to have a way to get blood into the lungs. So they'll use either a Blalock-Taussig shunt, which can cause subclavian steal that can be shown on ultrasound, just like a regular subclavian steal. And then you are going to have, or you can utilize a Sano shunt instead. So stage 2 is a Glenn procedure, and a Glenn can be used, well, it is used basically to replace the Blalock-Taussig or Sano shunt with the goal of having blood return being passive instead of arterial, which is what we'll end up having eventually when we're done this whole 3-step procedure. So Blalock-Taussig is taken down, and the Glenn is placed. Now, the Glenn is a vein to an artery, so it's the SVC to the right pulmonary artery, something like this. So here's your SVC, and there's your Glenn. It's sort of bypassing the heart, and it's just passive blood return. Now, last procedure that's done, and it's done around 1.5 years to 5 years, is the Fontaine procedure. And so this is going to make, the goal of this procedure is going to be, one, that the right ventricle becomes a systemic pump completely. And then the second part is that blood return to the lungs is done completely passively. So remember that the right ventricle's job in a normal person is to pump blood to the lungs. Well, if you're going to use the right ventricle to pump blood to the body, it can't do both. So you just have to make the best that you can and have the blood return to the lungs passively. So how this is done is the ASD is closed, and a shunt is placed between the right atrium and left pulmonary artery. So now we've got blood coming back to the lungs passively, and we've got the right ventricle acting as a systemic pump. And that's our end game, and that's as long as it will last. I know all that's complicated. I think the thing that's most testable is this, that the Glenn procedure is a vein to an artery, and that the Blalock-Taussig is an artery to an artery. It just seems like that would make a great question, great distractors. There's a whole bunch of different ways you could ask what a Glenn is, what a Blalock-Taussig is. Those are the things that are most likely to come up. The other procedures are just too complicated, and let's be honest, most radiologists don't understand that. So now we're going to talk about transposition. You can remember that transposition is essentially your aorta is hooked up on the right side, and your main pulmonary artery is hooked up on the left side, which is transposed. It's backwards. Now, the only ones that really need fixed are the D types, the ones that are doomed, which is the one that I'm showing here. Remember that the L type is the double discordant, where your ventricles are switched and the aorta and the PA switched, so that you're still being able to get systemic, you're still being able to complete the circuit. So let's look at these two. These are 2 different CTs. I've animated them to make them easier to see what's going on. This is what an L-type transposition looks like. Notice the position of the arch is to the left. So notice this is on the left here. And this is a D-type. And the D-type is on the right. Remember that, well, you can just L for left and D for right. It's easy to remember. So that is the distinction right there. Now there are 4 ways to correct this. 2 of them are from the Stone Age, which is these 2. And then these are your more modern procedures here. The Senning and the Mustard essentially use a baffle system to correct the transposition of flow. The downside to them is that the right ventricular remains a systemic pump, which ultimately causes problems because the RV is not built to be a systemic pump. The Rastelli procedure, which is probably the most common procedure overall that's used for transposition, also uses a baffle, but it does it in a way that allows the left ventricle to regain its role as a systemic pump. And then the last procedure is really the best one overall for a couple of reasons. One, it does allow the left ventricle to act as a systemic pump. And 2, there's no baffles or conduits or anything for the kid to outgrow. The Rastelli procedure basically locks the kid into a cycle of continuous surgeries where they have to keep going back and upgrading his baffle and his conduit and stuff like that. You are hopefully one and done with this guy. So why wouldn't they just do this one every single time? Well, there's 2 reasons. One, it's very technically challenging, difficult to do. There's only a few people that can do it well. The other thing is that if you have a large subaortic VSD or left ventricular outlet obstruction, you can't do that one as easily, and that's when you end up with the Rastelli procedure. And that'll make more sense when I animate it and show it to you. So let's talk about the old ones first. Basically, the restoration of flow occurs by shunting blood from the right atrium to the left ventricle and the left atrium to the right ventricle. Something like this. So here's an animation of the heart. The black circle there is the input from the vena cava. And if you create sort of a mesh, or you can use pericardium, and the difference between these 2 ones are just the materials basically that are used. You don't need I can't imagine that being asked. It'd be really obscure data, especially since they don't even do these stupid procedures anymore, very rarely. I think the take-home points are just sort of understanding them. So a baffle is created using something, let's just say pericardium, and it redirects the flow from the right atrium into the left ventricle, and from the right ventricle, or from the left atrium to the right ventricle. Like that. And you can see how that would allow oxygenated blood to be going out into the systemic circulation and unoxygenated blood to be pushed into the pulmonary artery where it can become oxygenated. So that's the first 2. Now let's talk about the Rastelli procedure. This one, like I said, the benefit is that it makes the left ventricle the systemic pump, which does way better. The downside is that you still are using conduits and baffles and shunts and these kinds of things, and they can wear out. So basically like this, you've got a patient who has a big VSD here and here, and the first thing that's done is that they tie off the main pulmonary artery here and then create a baffle here. So why did they tie it off? Tied it off so that blood doesn't you're not sharing your blood between this pathway and that pathway. The next thing that's done is that a conduit is created from the right ventricle into the pulmonary artery, sort of bypassing that. That's sort of on the outside of the heart. And you can see that in this technique, the switching is made at the level of the ventricle, not the level of the atrium. That would make a good question. Which of the following makes the switch at the level of the ventricle? This one does. Which of the following makes the switch at the level of the atrium? the mustard and ascending do, the old ones. So what you end up with is, here's a blood cell, and it's going to go like that and make it out into the lungs like normally would. Or you're going to have a blood cell that can go like that and out and be oxygenated and go out into the body and do its thing. So there, the switch is at the level of the ventricle. And then finally, the Jettine procedure, which is the best one, but like I said, most technically challenging. It's not going to utilize a baffle, and is instead essentially going to, we're gonna cut the coronaries out, cut the coronary out with like a button of tissue, and then they're literally going to switch the trunk of the PA and the aorta, just switch them. So this is a preoperative D type. Remember, it's on the right as opposed to the L type, which would be on the left. And this is a postoperative one, and it's got a very unique appearance with like the pulmonary artery draped over the aorta, like it's wearing a wig. So like you can imagine, like this person's very happy that they've had this procedure, and that they have beautiful hair that's flowing down there. So it's really a weird look, right? It's the only time you ever see something like that. It's an Aunt Minnie. It could be shown to you as such. What has this procedure had? He's had a Jettine procedure. Specifically, there's a fancy French-sounding name to this positioning that occurs. A surgeon actually manually does this switch. This is called the Lecomte maneuver, where there's an actual switching of the position that's done during the surgery. Anyway, you end up with that thing. Looks like the aorta is wearing a wig. That only occurs with this. It's an Aunt Minnie. That's why I'm showing it to you. So here's just a quick review. So this is what transposed D-type anatomy looks like. This is the old school ones, the ones that came first. Remember, A comes first in the alphabet, so the level of the switch is at the atrium. It's done with a baffle. It's bad because the right ventricle remains a systemic pump, and it ends up dilating and arrhythmias and failing and those kinds of things because it's not designed to do that. Rastelli procedure is more modern. It's done in a patient who has a big VSD. The switch occurs at the level of the ventricle because it's more modern. And the left ventricle remains a systemic pump, which is good. Downside is that patients often grow out of these baffles and conduits, which require reintervention. And lastly, here's the best one overall, if you can have one, and it's basically a direct switch. Coronaries are cut out, replanted, and the PA and the aorta are directly switched, correcting the anomaly. Okay, so congenital aortic valvular disease, or acquired through rheumatic heart, if the aorta is bad early on as a kid, there is a procedure that they will do called the Ross procedure. And the reason that this is done is because it allows the kid to grow and the valve to grow and not require multiple reinterventions. So what they do is they cut the bad part of the aorta out, including the valve. They move the pulmonary artery over, the pulmonary valve over, reimplant the coronaries, and then they use a graft for the pulmonary position. So, summarizing, the aortic valve is removed, it's garbage. The patient's pulmonary valve is put where the aortic valve is, and the pulmonary valve is replaced with a homograft. And the benefit of this procedure is that you can grow up with it, and it will, the valve grows. And a way to remember it could be, the only guy named Ross that I know is the stupid beta male character from the TV show Friends. And if you grew up with that, you can remember that you can grow up with your valve, your aortic valve, with a Ross procedure. Okay, this is the last one, and this is a surgery that's done to repair aortic aneurysms, specifically those that have annular ectasia, like the Marfan's aorta. Looks like a tulip bulb. I talked about this in the vascular lecture. So there's a specific procedure that's done where the valve is replaced, the coronaries are reimplanted into this graft thing, and a graft replacement of the root and ascending aorta is used. And this is called a Bentel procedure. And it's just a specific type of ascending aortic aneurysm repair that also repairs the valve, replaces the valve. And because that kind of an aneurysm is seen with Marfan's, that's the association. So this concludes the part 2 of the cardiac talks, and the next talk is going to be a lecture on cardiac MRI.